Bowel cancer is terribly common. It's number 3 in the world, number 3 in the UK. 50,000 patients a year suffer this disease, so it's important. And the drugs that we use to treat it are called 5-fluorouracil and capecitabine. Now, they're used to treat not only bowel cancer, but breast, stomach, pancreas, many other tumour types. They've been around for about 50 years, but they do carry quite a serious pattern of side effects. So the basis of ToxNav is us looking at the genetics of an enzyme called DPYD. Its big long name is dihydropyrimidine dehydrogenase. Why is that important? Because that's the enzyme, this is a protein within the body, that's responsible for deactivating 5-fluorouracil. So if you've got a low level of DPYD within the body, it means that for any given dose of drug, you'll generate much higher levels of 5-fluorouracil in the bloodstream with a much, much higher chance of side effects, toxicity, even a greater likelihood of death. What happens is that very high concentrations of the drug get into the bloodstream, travel around the body and damage the bowel, torrential diarrhea, torrential inflammation of the bowel that can lead to dehydration, renal failure, a terrible effect on the bone marrow, so the white cells can be destroyed, hugely lowering the capacity of the individual to fight infection. And very commonly, it's that septicemia, it's germs that get into the bloodstream that precipitate death. It can have a terrible effect on the lining of the mouth, so those individuals who are so affected cannot eat, who cannot drink, they have ulcers bleeding from within the mouth. It's very, very painful. It requires morphine and sedation to be able to deal with it. It can affect the skin with blistering of the palms and soles and hands and feet. And the real problem is that once the process has started, it's inexorable. It continues, it progresses, and we do our very best to maintain patients, to support them, to give them fluids, to have them in life support machines and so on. But despite the very best the health service can offer, the very best physicians, intensive care, still we lose patients because the body is so weakened by the effects of the drug. From the sums that we've done, from the calculations looking at the number of individuals who receive these drugs, 5-fluorouracil and capecitabine, we think that there could be some hundreds of unnecessary deaths per year. This is unacceptable. Estimations put the figure, it could be between 300 to 500, estimations only, but showing the potential size of the problem. But of course, beyond that, the tip of the iceberg, are those patients who suffer very serious side effects, who may end up in hospital, who may end up being quite significantly injured by the side effects of drugs. And that comes into the thousands of patients, 3, 4, 5,000 patients a year, that sort of order of it. So the mandate for driving this test forward, getting into this arena of science, is the individual patient, of course, protecting them first and foremost. But there are health economic reasons too. If we look at the cost, if I can use that rather hard term, to the health service, we can reduce the cost by reducing the burden of toxicity, patients coming into hospital and so on. So we would say that it would be win-win for the individual, but also for the treating hospital, that across our socialised healthcare system as a whole, something that we're proud of, we should save money. Timing's important, isn't it? And the application of the ToxNav test must come before chemotherapy is initiated, because some of those patients who are completely deficient in the DPYD gene, on their first dose of chemotherapy will die. And therefore this test must be initiated before chemotherapy starts. That's why it's terribly important that the ToxNav test is done in a quick and timely fashion. And our commitment from Oxford Cancer Biomarkers is that when we receive the blood sample from individual patients, from clinicians, that we'll turn this around very quickly indeed, so that we don't impact negatively time-wise on the patient's cancer journey, but will make a huge difference in terms of identifying those in advance of treatment. That's the important key element to all of this. There's no point in doing the test after the patient has suffered horrendous toxicity. You know, the horse is bolted, the stable door's been opened, whatever the analogy is. It must be done prior to initiating chemotherapy with 5-FU and capecitabine. So the ToxNav test looks at the genetics of DPYD and another enzyme. And by looking at this complicated genetic test, which looks at 19, 20 different variants of the gene, we feel that it gives us a very precise test for being able to identify those individuals, the patients I look after, who are at a much higher likelihood of developing side effects. So we take a blood test, we bring it into the laboratory, do some quite complicated genetic sequencing, and our test covers more genetic variants than any other. That's important because it means that there's a greater likelihood of detecting rare variants. Some of these variants are maybe confined to different ethnic groups and so on, but we feel that by casting the net wider, by being able to identify a wider population of individuals who may be at risk, our test is safer, I think it's improved, and it gives me greater confidence. So we think that this test will be impactful in that sense. And in terms of the scope, the width of its capture of the genetic abnormalities is the best out there at the moment.